So I'll dive straight into the questions. So I know we've just been talking about in the conclusion around NICE guidance. So one of the questions was, NICE guidance does not reflect the personalization of treatments that you mentioned in the presentation today. And I know some of the delegates have heard of the ADA EASD consensus statement. Could we use that particular guideline to guide our clinical decision making?
Yeah, I mean, these guidelines are all fairly consistent.
Okay.
And what they say is identify patients with high cardiovascular and renal risk.
Okay.
And be very clear that in those patients, the best way to manage that risk will be to ensure that they are taking an SGLT2 inhibitor, such as a drug like canagliflozin, where you have very robust evidence of benefit versus risk. These patients may already be on insulin. They may be on other diabetes therapies as well, but they need to be on an SGLT2 inhibitor.
Okay. So leading on from that question, another question we had was, given DPP-4s and even pioglitazone has a case for deprescribing, as per NICE guidance, is there a situation where you may deprescribe an SGLT2?
I wouldn't deprescribe an SGLT2 inhibitor unless the patient was having an adverse effect. And the commonest adverse effect in practice is genital mycotic infection. There is a very small risk of ketoacidosis, but that risk will only occur if the patient becomes unwell for some other reason. So the advice to patients who are taking metformin, for example, is if you become sick and you're vomiting for some reason, stop your metformin because you might get lactic acidosis. And we would similarly say to patients on an SGLT2 inhibitor, if you become unwell for some other reason, you're vomiting, you're not maintaining your hydration, stop the SGLT2 inhibitor because there's a very small risk that you could develop ketoacidosis. But people are not going to develop ketoacidosis who are otherwise well. They're only going to develop ketoacidosis if they get run over by a bus or they've got a raging pneumonia and they come into hospital.
Okay. Right. Next question was SGLT2s and fracture risk. Is that a big issue, a big concern?
It's not a concern at all. It's not a concern at all. It was reported a very, very small population risk with drugs like pioglitazone and a very, very small population risk with an SGLT2 inhibitor, but no.
Okay.
Pretty hen's teeth stuff.
Next question was the use of SGLT2s and the volume depletion that's mentioned with their use, and in patients with thiazides, diuretics, and obviously, you've talked about the benefits in heart failure. Is that a major concern, or in primary care, should we move forward with that?
You would add the SGLT2 inhibitor on top of usual care, which would include an ACE inhibitor. It might well include a diuretic. On the labeling of the SGLT2 inhibitor, there is a caution about use with loop diuretics like furosemide. And the only reason for that caution is in regard to blood pressure. So if your patient has got a low level of blood pressure, you might want to be cautious that you don't cause a little bit of a hypotensive reaction. But if, as in most patients on stable therapy with ACE inhibitors and other drugs, if their blood pressure is within a reasonably normal range, there would be no reason not to just add in the SGLT2 inhibitor.
Okay. So leading on from the from that particular question around diuretics, there was a particular question around thiazides, and are thiazides appropriate for the management of BP in patients with diabetic kidney disease, given the association of thiazides to increase glucose levels?
I wouldn't be using a thiazide for blood pressure control in a patient with diabetic kidney disease. I'd be using an ACE inhibitor. I'd probably be using a loop diuretic if I needed it. And I'd certainly be using an SGLT2 inhibitor if they've got a raised albumin creatinine ratio on a urine sample.
Okay. So you've covered the DKA. You've spoken about credence, and at the moment, canagliflozin is the only SGLT2 with renal data and evidence, and quite significant evidence. Are there any others within the class with similar evidence available at the moment? No.
No. So there was a little bit of indirect evidence in EMPA-REG, as there was in CANVAS, of reduction in proteinuria and preservation of EGFR. But credence is the only outcome trial performed specifically in patients with chronic kidney disease. And the other point I didn't mention is that in credence, 4,500 patients with very high risk because of CKD, there was no amputation signal with respect to canagliflozin. So that small amputation signal that was seen in CANVAS has not been repeated in credence, even though we might argue that the credence population were far more fragile in a general sense because of their CKD. So that is actually also extremely reassuring around this amputation signal that we saw in CANVAS.
Okay, so again, just a further question leading on from the LLA. The evidence suggests that it may be there, even despite the small amount. In practice, in reality, how common is it really?
Extremely uncommon, extremely. And the only message I would give in primary care is, if your patient hasn't got 10 toes, then I wouldn't initiate the drug. If they've already had previous foot amputation, then I would probably not use the drug, unless you can have a good conversation with the patient about informed consent. Because those patients, of course, with prior amputation probably have extremely high cardiovascular risk and actually would probably benefit enormously from the SGLT2 inhibitor. But unless you can have a good risk-benefit conversation with the patient, in primary care, I would probably avoid it if they've had previous amputation.
Yeah, okay. And then lastly, so we've got a lot of practice-based pharmacists on the webinar tonight. One of the questions was, if I was to go into work tomorrow and that person's involved in clinical audit, so if they were to go tomorrow to work and find one patient or two patient cohorts to make a real impact in their practice, what would you suggest to look at?
Go and find all your patients with documented previous acute coronary syndrome, patients who've got a diagnosis of heart failure and diabetes, and patients who've got known diabetic renal disease with an EGFR above 60. And check if those patients are on an SGLT2 inhibitor, irrespective of their HbA1c.
Okay.
And add in the SGLT2 inhibitor, and if you like, substitute it and stop the DPP4 inhibitor if their A1C control is actually quite good.
Okay. Roller spironolactone. I don't know, Christine, if you want to give some more context around what you're asking. Is it in diabetic?
I mean, spironolactone at the moment is really evidenced around heart failure, and specifically heart failure with reduced ejection fraction.
And that's in addition to a loop, isn't it?
It is in addition to a loop. Your patients with diabetes are more likely to have heart failure with preserved ejection fraction.
Right. Okay.
And again, these drugs would be used as add-on to usual care.
Okay.